All right, so we're going to go ahead and get started. Everyone, welcome to Get Your Rear in Gear with Dr. Tracey Proverbs-Singh. Just a few quick notes before we start the presentation. Please hold your questions until the end of the presentation, and you can use the chat box or the Q&A when asking your question. On behalf of the Library Director, Sai Rao, and all of our library staff, I would like to start by thanking Hackensack Meridian Palisades Medical Center, Nikki Medeiros, Kristen Wilkes, and Dr. Tracey Proverbs-Singh for generously donating their time to organize and appear at this event. We greatly appreciate you being here. Dr. Tracey Proverbs-Singh specializes in the care of patients with gastrointestinal malignancies at John Theurer Cancer Center. She also has extensive experience in clinical research with a focus on understanding the side effects of cancer treatment and investigating novel toxic therapies for solid tumors. She has presented her work at numerous professional meetings, including the American Society of Clinical Oncology, American Association for Cancer Research, United States and Canadian Academy of Pathology, and the San Antonio Breast Cancer Symposium, among others. She has contributed to published manuscripts in the prestigious Journal of National Cancer Institute, Journal of Clinical Oncology, and JAMA Oncology. She was honored with the prestigious Brian Piccolo Endowed Fellowship at Memorial Sloan Kettering Cancer Center. Dr. Proverbs-Singh is an associate member of ASCO and the American Society of Hematology, and she participated in the esteemed ASCO, American Association of Clinical Research Methods, in Clinical Cancer Research Workshop. Doctor, I'll turn things over to you.
Hi, thank you so much for that wonderful introduction. I'm just going to share my screen. Can everybody see everything okay?
I'm not seeing the screen.
Not quite yet.
Okay, let's try this way.
There we go. Now I can see your screen.
Okay. Okay, there we go. So you can see it okay now? Okay, perfect. Okay, good evening, everybody, and thank you so much for joining us today. I think with Colon Cancer Awareness Month, this is an incredibly important topic because this is one of the most prevalent cancers that we deal with as GI medical oncologists. You know, this is one of those cancers that we emphasize early detection. And so I'm happy to talk to you about colon cancer today. We call it Get Your Rear in Gear as kind of a pun because we know everybody just loves colonoscopies. And basically knowledge is power. Understanding how to not only screen and prevent colon cancer is important. So we just have a couple of slides that briefly go over colon cancer and what it's about. So again, this is Colon Cancer Awareness Month. This is the time to get family and friends out there and aware of colon cancer and the screening for it. Today, we're going to focus on the very simple topics of what is colon cancer in general, who does colon cancer affect, what puts us at risk, and how do we screen, how do we diagnose, and then what about staging and treatment. So obviously, this is a huge section. We focus on GI oncology, so I'll hit the basics and please feel free to ask any questions. So colon cancer, what is it? So it's something just simply a cancer that starts in the colon. Our colon is made up, if you can see in this picture, of not only our colon, but also our rectum. So when somebody says colorectal cancer or rectal cancer, that is all considered the same thing, a colon cancer. It's all one tube that starts on the right side of the colon. So we're opposite here. The right is the cecum, goes all the way up the ascending colon, across the transverse colon, down the descending colon, the sigmoid, and then out the rectum. The anus is down here. It's not included in colorectal cancers. This is just the pictorial of what typical colon cancer seen if found on a colonoscopy. You could see the lumen of the bowel, and then here is the tumor. That's not supposed to be there. Basically, treatment depends on the location. So again, I talked about the different areas. Whether your cancer is on the right side or in the rectum does make a difference in terms of what types of treatments you're offered. And colon cancer usually starts as a precancerous polyp. This is why early detection is key. And this is why so many people emphasize colonoscopies and screening. How many people are affected by colon cancer? So colon cancer is the third leading cause of cancer death in men and the second leading cause in women. In women, breast cancer is leading, and in men, it's prostate and lung cancer. We know that colon cancer is a disease of aging. So as people get older, their risk of colon cancer goes up. This is why historically, colon cancer screening started at age 50, because this is when we see the curve start to rise. The number of cases are increasing worldwide, but in the US, cases are actually declining, mostly because of screening, mostly because people are getting colonoscopies. The one difference is that colon cancer is actually changing in the US. We're seeing the overall incidence lowering, but in patients in lower age groups, so people under the age of 50, that's actually increasing. And so screening guidelines have changed, and I'll get into that. Colon cancer affects both genders relatively equally, although men are a little bit more affected. On the left here shows us the incidence, or how often colon cancer happens. And we can see that it's at a rate of 40 per 100,000 people. So usually about 4 or 5% of patients will be at risk for colon cancer in their lifetimes. We know that most of it ends up being in the colon, a smaller proportion in the rectum. Again, the distribution is similar. Mostly men have a slightly higher incidence of colon cancer. With that, we also see men have a higher risk of mortality. The things that increase our risk of colon cancer are a lot of environmental factors. We know that genetics play in younger colon cancers. There's several genetic and familial patterns of colon cancer inheritance. But generally speaking, the average person, it's just the development of polyps over time that eventually turn into cancer. We know there's certain things that increase the risk of polyp formation and thus colon cancer. Some of these are people who have very limited or low physical exercise, unhealthy diets with a lot of fat, low fiber diets. Smoking does increase the risk. Obesity does increase the risk, as well as obviously age. As we can see from this panel, we talk about things like modifiable risk factors, things that you can change in your lifestyle, versus not modifiable risk factors. Age you can't change, but we can change our influence in terms of whether we smoke or whether we alter our diet to include more fruits and vegetables. The things that we look for, so we think of, the risk factors we talked about, and now what are the signs or symptoms that we may have a problem in our colon and need to be investigated. Sometimes when people have frequent or stomach gas pains, things that are unrelenting. So we talk about symptoms over a 2-week period of time where standard over-the-counter interventions have not been beneficial. If that comes to that point, then you should seek medical attention because it says that maybe something's off. So things like stomach pains or frequent gas that you're having that's increasing in intensity or frequency. Change in bowel habits. We think about new constipation or new diarrhea or stools that change in terms of caliber. So they become pencil thin or incomplete evacuation. So somebody goes to the bathroom and they still feel like something's in there. These are things that you should alert, that kind of flag somebody to alert their physician that something's going on. Obviously, any blood and bowel movements is not normal if there was not a prior diagnosis of hemorrhoids or something else. Again, if you have prior history of hemorrhoids, blood in the stool that's increasing in frequency, anything that's changing over time is something to alert one's physician. Feeling weak or tired consistently, combined with any of these symptoms. And then once you do see, and then black or tar stools, so stools that are not only red or bloody, but sometimes stools that are black, stools that look almost like tar that you would put on the driveway. That's not a normal color consistency. That sort of thing would flag you to worry about blood being in the stool. And then when you see your doctor, if there's low iron, anemia, those are things that can affect, that can say there's something going on in the bowels and should seek medical attention. So I alluded to this when I talked about colon cancer development, but there's a very clean sequence of events that occur from polyp to cancer. We know as medical oncologists that there are a slew of mutations that occur in normal tissue that ultimately lead to growth of these cells in an abnormal way. And that ultimately leads to having a polyp. All of this is not a cancer, but these are abnormal growths. When we get to the point of increased genetic changes within that polyp, so not in a person, but in the polyp itself, that then triggers a slew of events that change that polyp to a cancer. And this is why we emphasizing catching things early in this phase before they've become a cancer. As that cancer sits there, eventually it figures out how to get through the membrane and into the bloodstream. That's what this kind of representation is. And it develops new mutations. So it goes from a hyperplastic kind of abnormal growth to an adenoma, which is those polyps that they take out, ultimately to a cancer. And so we can almost predict that slew of events depending on what that polyp looks like. So how do we diagnose colon cancer? Most people are fully aware of the colonoscopy, and a lot of people have a lot of misconceptions or pre-existing ideas about what a colonoscopy is. This is performed by the gastroenterologist, so somebody who specializes in procedures of the colon. Screening colonoscopies are things that we call, I don't have symptoms, I feel great, but this is one of the screening tests to make sure I don't have any polyps. That used to start at age 50. The guidelines have changed because, as I mentioned before, the age distribution of colon cancer has changed. And we're seeing younger patients with colon cancer. And so now the American Cancer Society recommends anybody over the age of 45, especially people in high risk groups. So if there's a family history, if there are other comorbidities or other medical problems that would pre-exist you to have a colon cancer, or in a situation, we know that sometimes certain ethnic groups have a higher proportion of colon cancer risk. So patients of African American, Hispanic descent can occasionally have higher risks of cancer. So we do recommend screening at age 45. A diagnostic colonoscopy, on the other hand, is not a screening colonoscopy. It means something's wrong. It means we do this anytime. So age is not a factor. If you have blood, if you have constipation, change in stool caliber, this becomes a diagnostic exam. We're looking for a problem. And so this is what your gastroenterologist will go through, talk about your symptoms, talk about what you're feeling, and then talk about what you need. In patients where it's diagnostic, they're going in looking for a problem. In screening, this is a healthy person. And so a lot of people, I mentioned, have pre-existing notions of why we do colonoscopies. The reason we do colonoscopies is because they're not only a diagnostic tool in the screening setting, but they're also a treatment tool. We know that if we find a precancerous polyp, so the left side of that picture that I showed you, we know that those patients do not have the risk of that polyp becoming a tumor. And so we've treated them as well as diagnosing them. We can remove precancerous polyps, and we decrease the risk of death from colon cancer. When they looked at the large population studies, we know that colonoscopies save lives. The rate of colon cancer has dropped in the US because of colonoscopies. So these are very good. Frequent reasons that patients opt out of colonoscopies, Often the idea of the bowel prep, so cleaning one's colon squeaky clean in order for the gastroenterologist to be able to see every nuance and every polyp does require, sometimes a day of preparation. The preps have improved, they're shorter, they require less volume, they make you less nauseated. So this is something to discuss with one's gastroenterologist about the new and improved preps for colonoscopies. And then some people have pre-existing conditions and worry about the idea of getting anesthesia. And so this again is something that you discuss with your gastroenterologist. There are alternatives in occasion and selected patients for screening. Many people have heard about Cologuard test where they check the stool. This was approved by the Food and Drug Administration in 2014, and this is only for selected patients of average risk. We're talking about patients between 50 and 70 who have no symptoms of colon cancer, no symptoms whatsoever, and used as a screening tool. They shouldn't have any family history of colon cancer or any significant risk factors. In this situation, the Cologuard is actually a multi-targeted test. It looks for tumor DNA, it looks for blood, and it's an algorithm that matches all of those things to predict one's risk of having colon cancer. It's highly sensitive for detecting colorectal cancer. So we know 92% of colorectal cancers can be picked up on Cologuard, but only about 42% can be picked up when we're looking at precancerous lesions. So sometimes these pre-malignant. So although a good test, we're identifying a lot of cancers, the hope is that we could identify and catch things early before they become a cancer. Alternatively, in patients who, for whatever reason, can't undergo a colonoscopy right away, a CAT scan, what we call a CT enterography, which is basically a virtual colonoscopy. It recreates the colon via CAT scan imaging. Fecal occult blood tests, if done in sequence, we call it serially, can elicit a problem in the colon, saying bleeding, but it's not sensitive for colon cancer and it's not specific. If any of these tests are positive, a patient would need a colonoscopy still. So these are alternatives, but not replacing a colonoscopy. So what happens after somebody is diagnosed? So say they get a colonoscopy and we find a colon cancer, what's next? And this is the frequent question that when patients arrive in my office that we get. Most patients have a diagnosis by the time I see them. And so we're working on discussing their staging, which is how much disease does a patient actually have? We know that they have a mass in their colon because their gastroenterologist usually finds that. And then the question is there anything else? The treatment is what is the best option for that individual based on the staging. So this is kind of a picture that represents what we do as oncologists. We try to sort through what stage a patient is in. Patients can go all the way from stage 0 with a polyp that has not turned cancerous yet, all the way to a stage 4 tumor. These are distinguished by not only the size of the tumor, but how far into the wall of the colon they go. So this is our colon, and this is the polyp. You can see the polyp is invading into the wall. So it does depend on how far into the wall it goes and whether or not lymph nodes near that polyp are part of the process. Do they look cancerous? And then stage 4 is when we see tumor outside the colon or the lymph nodes move beyond that into a different organ. For stage 0 and stage 1, frequently patients need only a polypectomy or a surgery and removal of that polyp area. Patients with stage 2 or 3 will need a surgery to remove the polyp in the cancerous area along with the lymph nodes that surround it. And then some patients in stage 2 or 3 do need chemotherapy after surgery. Stage 4 disease, surgery can be used occasionally, but frequently treatment is systemic or whole body. It has to go through the bloodstream. This consists of chemotherapy, targeted therapy, sometimes immunotherapy, and clinical trials, which is something at the John Theurer Cancer Center we specialize in. We do phase 1 early development. We know that the stage matters in terms of survival. The earlier a patient is diagnosed, the greater the likelihood that they are to survive over time. In oncology, we look at something called 5-year survivals. So 5-year survivals are how long we anticipate a patient's going to live given the diagnosis they've been handed, and what proportion of patients will live to 5 years. This curve is a little bit complicated, but you can see stage 1, 100% survivals at the top. So you would see a straight line if it was 100%. In stage 1, the line is almost straight. When we get to stage 2, 3, and then 4, we can see the survival decreases. We know the later the cancer is found, unfortunately, the lower the survival. We know that we have treatments regardless of stage, and not all colon cancer is the same. We can't compare our neighbor's colon cancer to our colon cancer because there's so many factors that go into what determines a treatment and what determines what type of surgery, what determines whether a patient needs additional therapy or targeted therapy. So first stage is the most important aspect. Then whether or not a patient is eligible for surgery, are they a stage 1 to a stage 3? Whether or not radiation is appropriate. And if patients are in the stage 4, where we have to give systemic therapy, this is where we look at the mutations or alterations that have happened in the tumor. Is there anything that makes this tumor vulnerable? In colon cancer, we have several new therapies that help us supplement our chemotherapy that aren't always as toxic as chemo. We have immunotherapies for a subset of patients. Generally, about 10 to 15% of patients will be eligible for immunotherapy based on their tumor profile. Also, targeted therapy. Again, we have anywhere from 20 to 30% of patients that may be eligible for targeted therapy because of their tumor profile. Chemotherapy is the backbone of treatment, and there's several different ways of giving and administering chemotherapy, as well as all the complementary medications that exist now to help support a patient getting through treatment. And so hopefully that was a short overview of the broad spectrum of colon cancer care. Things have evolved dramatically over the years. There are new therapies based on tumor profiling. We still use chemotherapy because it's the backbone of therapy, but there are many new prospects. And at the John Theurer Cancer Center, we do a lot of clinical trials. So in patients who have advanced disease, or even we do some trials about side effects, and circulating tumor cells are in the works. Immunotherapies help us to look for the future and look for novel, less toxic treatments for our patients. So, thank you for your attention, and I'll turn the page over to any questions if there are any.
So we do have one question in the chat box from Ruth. She's asking, what attributes to a higher risk of cancer in older people?
So that's actually a pretty simple question. The longer we live, the longer we have a chance to develop mutations. So when I talk about the development of colon cancer, you think of over time mutations can occur. These are your normal body mechanisms that are there to control growth and to control survival of cells, to keep our bodies healthy and regulated. But these same systems can go awry occasionally. And that's where you start developing something called hyperplasia and abnormal growth, and getting these kind of mutational abnormalities. The older we get, the more likely and the more we accumulate that sort of system. So we see more polyps as we get older, we see more changes, and people are more at risk for these cancers. But again, we've done significant efforts in decreasing that effort because people are finding, if they do screening colonoscopies, we find the polyps early in that stage. And even if they're removing 10 polyps, those polyps never have the chance to form cancers. And so we really are making an impact. So that's why, but we have a way to change and augment that.
Another question, is there an age where you would stop getting colonoscopies if all is okay?
So technically speaking, the guidelines do have age endpoints. So, and it's a little bit more complicated now that people are living longer and healthier. So if you go strictly by the guidelines, depending on which guidelines you look at, either the age of 70 or 75 if all colonoscopies have been normal. But then there's a new caveat on all of these guidelines that if a patient has a life expectancy of greater than 10 years and otherwise healthy, then we continue screening. So say somebody has been healthy their whole life and they're 80 and we anticipate they should have another decade of life because, you know, everybody in their family lived that long. It's a discussion with your gastroenterologist about the risks and benefits of getting the colonoscopy, and then deciding whether or not that screening is appropriate. So yes, we see several patients of older ages getting colonoscopies, but that's based on how healthy that person is.
Another question, what is the best diet to keep our colons healthy?
It's a very simple and boring diet. What we know is that kind of that heart healthy DASH diet that's very tough to maintain. Low sugar, low fat, low processed food, low salt, all keeps the colon healthy. Fruits and vegetables, fiber, things that keep your colon moving. Those are the things that are beneficial. We know that exercise plays a role. There's several studies that look at exercise after a person's had colon cancer as reducing the risk. Obesity is technically one of the risk factors, and we have several obesity-related cancers. Obesity is actually smoking as the leading cause of cancer in the United States. So we know these are modifiable factors that we can change and improve upon. Obviously, we have very healthy, energetic patients that don't have those risk factors that do develop colon cancers, but at least we know we can reduce our risk by doing some of these modifications.
Does junk food and sodas cause colon cancer?
Not directly, but it goes along with the same modifiable risk factors. What can we do to change or augment our risk? Eating healthy, you know, generally, most of the time is preferred. Our colon likes it. Obviously, you know, having a cookie every now and then is not going to increase your risk. Having a soda every now and then, but it's what you're doing on a day-to-day basis. What is the norm? So indirectly probably contributing to an overall unhealthy lifestyle, but not directly causing it. So drinking a can of soda won't cause a polyp the next day, but trying to maintain a healthy lifestyle is important.
If anyone has any other questions, please feel free to put them in the chat box.
I was so clear.
It looks like that's all the questions we had this evening. So thank you everyone so much for attending this evening. Thank you again to the Hackensack Meridian Palisades Medical Center. Thank you, Dr. Proverbs-Singh. Thank you, Nikki. Thank you, Kristen, and everyone for coming out this evening.
Thank you, guys.